opportunity to talk to you today about oral health consideration among cancer survivors. As you all know, cancer survivors are potentially at risk of having a wide range of chronic complication as well as acute complication that can happen after the discontinuation of cancer treatment. And these can be classified as acute toxicity or late toxicity. There are some of these complications remains underreported, underrecognized, and therefore undertreated. Why is that? Because the oral cavity is very vulnerable to the toxic side effects of cancer therapy, whether it is surgery, radiation, chemotherapy, or any other treatment modality, and it can happen as an acute toxicity, such as a mucositis and oral infection. And the good news about the acute toxicity that most of them will resolve at the end of the cancer therapy. Our major concern is with a late complication such as salivary gland hypofunction, oral infection, oral chronic graft versus host disease, osteonecrosis of the jaw, trismus, and secondary cancer. We believe that aggressive management of these kind of complication is necessary to ensure optimal long-term oral health and the general well-being. And that's why we strongly recommend in order to prevent or minimize such a complication, there should be a good communication and a well-integrated communication between the dental and the medical providers before, during, and after cancer therapy. So the aim of this lecture is to discuss the potential chronic oral complication as a result of cancer therapy and their management. In order to do that, we'll talk shortly about the principle behind complications, because as a dentist, we need to understand the underlying mechanism of these toxicity, and then we'll talk about what we can do to prevent these kind of complication, and we will talk briefly about the different types of late oral complications and the need for the long-term follow-up, and then I'll end my speech with the psychoeconomic impact of these complications on the patients. Generally speaking, cancer can be treated either by surgery, radiation therapy, chemotherapy, hematopoietic stem cell transplant for hematological malignancy, or the use of anti-resorptive treatment in case of certain types of cancer. Regardless of this type of treatment modality, each one of them will contribute to the development of certain complication in the oral cavity. For example, the surgical related complication usually are limited to patients with head and neck cancer due to the close proximity of the vital structure of speech, swallowing, respiration to this kind of surgery. Therefore, and because the head and neck area is the most visible and most noticeable part of the human body, even a minor surgical defect can have a tremendous impact on the social interaction and the self-image. Despite the advances in the surgical reconstruction, still the patient may be left with a significant disfigurement following surgical resection. Also, due to the nerve and tissue damage, there will be some myofascial and neuropathic pain, in addition to the scarring and fibrosis of the tissue, which lead to trismus and impairment in speech and swallowing. How about radiation therapy? We know that radiation therapy uses ionizing radiation, and as this kind of radiation passes through the tissue, it will cause ionization and the release of highly reactive species, or what we call it free radicals, which will induce a double DNA strand break and lead to the apoptosis of the cell. And we know that radiation is not specific for the cancer cell. Therefore, any tissue with a rapidly proliferating cells with a high mitotic activity will be affected adversely by this kind of ionization. Generally speaking, head and neck cancer can be treated with a cumulative dose of 50 to 70 gray, although this is given as in a fractionated dose over 5 to 7 weeks, but still the cumulative dose will be enough to cause a permanent changes in the salivary gland, in the bone, in the soft tissue, and obviously the amount of damage is influenced by the type of radiation, the dose, the intensity of radiation therapy, and the anatomic structure exposed. How about chemotherapy? Again, chemotherapy is not specific medication, and therefore it will target any cells with a high mitotic index, especially hair follicles, mucosal cell, intestinal mucosa, in addition to the bone marrow cells. Therefore, acute toxicity will happen as a result of this chemotherapy in form of what we call it a mucositis that appear as erythema, ulceration, which can involve any part of the oral cavity, and this kind of toxicity causing a severe pain and the discomfort to the patient. Sometimes it needs hospitalization, stopping of the cancer therapy, as well as a strong analgesic like morphine, in addition to the limitation and the restriction of the food, which will lead to dehydration of the patient. Although acute toxicity with a chemotherapy has been well characterized in the literature, the late oral complication from the chemotherapy is not very well described, but there are certain chemotherapeutic agents that can cause a neuropathic pain, like doxorubicin. How about hematopoietic cell transplant-related complication? We know that in the bone marrow transplant, there will be infusion of the hematopoietic stem cell after a conditioning regimen with a high doses of radiation, with high doses of chemotherapy, with or without total body of radiation, and then infusion of the hematopoietic stem cell to reestablish the hematopoietic function in a patient with a hematological malignancy and bone marrow failure syndrome. Whether this is accomplished as an autologous bone marrow transplant or allograft bone marrow transplant, those patients will be at a different level of risk with regard to the acute and the late oral complication. Mainly the graft versus host disease, which is considered to be the main reason for morbidity and the mortality in a patient with allograft bone marrow transplant, because it needs a long-term immunosuppression, which will put the patient of a high risk of infection and the emergence of secondary cancer. How about anti-resorptive therapy? As you know, a certain type of cancer like multiple myeloma, breast cancer, and prostate cancer, there will be a problem with the skeletal-related events due to the bone pain, which might lead to a fracture due to the metastasis of the cancer. Therefore, the use of the intensive intravenous bisphosphonate and denosumab, which is a newly marketed medication, has demonstrated an efficacy in reducing the skeletal-related events and improve the overall survival, and this became a standard of care in these cancer patients. Both medication, whether the intravenous bisphosphonate together with the denosumab, they work primarily by inhibiting osteoclast and induction of apoptosis of the osteoclast. And we know that bone is a highly dynamic organ, and there should be a balance between osteoclast and osteoblast activity. Therefore, if these kind of medication inhibit one part of the equation, there will be a disturbance of the dynamic activity of the bone, and this will increase the risk for osteonecrosis of the bone later on. So what we can do generally in order to prevent or minimize these kind of complications? Well, the primary objective of a pre-cancer therapy dental screening is to achieve a stable and infection-free oral cavity in order to reduce the risk of developing localized or systemic infection. There is no universal consensus for what's considered necessary dental treatment prior to initiation of cancer therapy, and the protocols largely depend on the expert opinion or institution protocol. But generally speaking, this kind of visit, or what we call it a pre-cancer dental screening, is usually accomplished 1 month, or it should be accomplished 1 month before starting the cancer treatment, to give us time to formulate an ideal treatment plan for the patient, as well as to give the time for the tissue healing. In this kind of visit, we should take the opportunity for collecting all the information relevant to the patient regarding the type of cancer, the treatment modality, and the timing of treatment is very important. If you cannot collect this information from the patient, then you have to contact his oncologist. After taking a good history from the patient, we start with a thorough examination that should include hard and soft tissue, as well as a radiographic evaluation to detect the possible source of infection and the teeth that may show a poor long-term prognosis. Well, at this time, you should consider the risk for osteonecrosis in the future, and therefore you need to extract all the teeth that might pose a problem in the future. Any teeth with a questionable prognosis, or for example, in a pediatric patient, if there is a teeth that's known to be exfoliated during the treatment, so also we need to take it out before. Generally speaking, we do oral surgery or extraction 2 weeks before radiation therapy and 7 to 10 days at least before starting chemotherapy. Also take the opportunity to educate the patient about proper oral home care, instruct him how to do a proper brushing, a flossing technique, and the point is to keep the mouth as moist and as clean as possible to reduce the risk of infection and pain. How about treatment during cancer therapy? Well, any kind of elective dental treatment should be deferred after the stopping or at the end of the cancer therapy. But again, we need to follow up those patients during cancer therapy to treat any emerging infection or ulceration, or also to manage mucositis. It's important to provide a dietary counseling during this time, and also teach exercise to reduce the trismus, which will be anticipated at the end of the treatment, and schedule dental appointment carefully. At this time, we have to determine the hematological status of the patient and the need for antibiotic prophylaxis in case of risk of infection. And then follow up oral care at the end of the cancer treatment, and once all the complication resolved, the patient may resume their normal dental care schedule. It's essential to evaluate the bleeding tendency and the infection before any kind of surgery, and the patient should be seen regularly every 4 to 8 weeks for the first 6 months, and thereafter based on the needs of patient. So let's review some of these late oral complications. The main one is salivary gland hypofunction. As you may know, salivary gland tissue is quite sensitive to radiation therapy. With a cumulative dose more than 30 gray, it's enough to cause a permanent changes and a permanent damage to the salivary gland. And this toxicity is directed by the direct cytotoxic effect of radiation therapy to the salivary acini, and the indirect damaging effect to the epithelial and the connective tissue of the salivary gland. So the outcome will be reduction in the salivary flow rate, not only in the quantity but also in the quality, and then we'll have more viscous or mucus saliva. And what's the sequela of hyposalivation? We know there will be a dryness and then cracking, fissuring of the oral cavity, increase the risk for acute infection like viral infection or candidal infection, and of course rampant caries. So how we can control this or can manage these kind of complications? Several approaches have been evaluated in terms of their efficacy in reduction of salivary gland damage. Like, for example, the use of intensity modulated radiation therapy, which is a kind of radiation modality that has more focusing effect on cancer cells while sparing the adjacent tissue. How about amifostine? Amifostine, it acts as a free radical scavenger, which can be injected subcutaneously or intravenously before the radiation therapy visit, and then there will be a reduction of salivary gland damage. Use of mucolytic agent, mouth-wetting agent. For some patients, we need to go further and prescribe some sialogogus medication like pilocarpine and civimilin. But again, these kind of medications should be restricted only for a limited patient because of their side effects and due to their non-specific action on the muscarinic receptors. Dental caries, again, fluoride application is very important. The use of antimicrobial mouth rinse like chlorhexidine, and active researcher in the field, actually, they came up with a certain devices that's known as a saliva pacemaker, which can help in inducing more saliva. Obviously, you have to have some remaining tissue of the salivary gland. And the first generation of these devices, based on the neuroelectrostimulation, came as a probe, which is handheld, that can be placed in the mouth, and then it can induce the salivary gland to produce saliva. The second generation, it came as a removable appliances, which can be placed in the patient's mouth, also can act as a neuroelectrostimulator. And then the third generation, which is the more sophisticated one, which is an implant-supported neuroelectrostimulation device. This is for the salivary gland hyperfunction. Then we'll go to other complication, which is oral infection. And the main two infection are oral candidiasis and herpes simplex virus infection. We know that candidiasis is the most common opportunistic infection and which can be more pronounced in a patient with a hyposalivation. So regardless of the cause, we can treat candidiasis topically by the use of nystatin or clotrimazole atrocious or systemically in case of moderate to severe oropharyngeal candidiasis by using fluconazole, itraconazole, or voriconazole, and amphotericin can be reserved for refractory cases. We should remember that even patients with removable appliances, we need to treat the denture as well by soaking the denture with antifungal agent and disinfecting solution. Oral herpes simplex virus infection, those patients or the cancer survivors, especially cancer survivors of allograft bone marrow transplant, they will be at a high risk of having recrudescent herpes simplex virus infection because of long-term immunosuppression, which will cause a significant pain and discomfort to the patient despite being on prophylactic acyclovir. The problem is that these cases tend to be more atypical and severe, and it takes long time for healing. So we need to treat this thoroughly by using a systemic antiviral medication. The other complication is the oral chronic graft versus host disease. We know that oral involvement of chronic graft versus host disease is quite common. More than 80% of the patients will have oral chronic graft versus host disease, which present intraorally as a lichenoid reaction, mucosal erythema, ulceration that can occur anywhere in the oral cavity. And how we treat this? Obviously, the first line of treatment is using topical corticosteroids. We have a great selection from a different preparation of corticosteroid with a different degree of potency that can be selected according to the severity of the lesion. Also, we have another modality by using intralesional injection or injectable corticosteroid, which can be used for a large and painful lesion. Then, if those cases do not respond to the corticosteroids, we go for tacrolimus, like a topical tacrolimus, protopic, which is quite effective in these cases. Osteonecrosis of the jaw, defined as exposed necrotic bone, which will occur in the oral cavity and persist for more than 8 weeks. We have two types of osteonecrosis, whether it is induced by radiation, then we call it osteoradionecrosis, or whether it is induced by intravenous bisphosphonate or denosumab, we call it osteonecrosis of the jaw, or we refer to it as a BRONJ, bisphosphonate-related osteonecrosis of the jaw. The main risk factor will be dental extraction or any kind of surgical trauma. However, we have to remember even 50% of the cases can occur spontaneously.
Still have 3 minutes.
Yeah. Okay, so this is the osteonecrosis of the jaw. Different sizes of the jaw can be exposed. This is one of my patients. Unfortunately, he came up with total exposure of the mandible, and then he passed away due to the complication of the treatment. Radiographically, we might see the moth-eaten appearance of the bone, and sometimes there will be pathological fracture. So treatment, this is a very challenging case for treatment. That's why prevention is a very important in this kind of complication. However, even if you do your prior pre-cancer treatment visit, still some cases can occur, and therefore you need to manage those cases depending on the stage of the bisphosphonate or of the osteonecrosis of the jaw, to optimize oral hygiene, use of antibiotic, nutritional support. Sometimes we can do sequestrectomy by removing of the sequester, reduction of dental extraction. The use of the hyperbaric oxygen, plus or minus, it might be helpful. And also, again, the use of low-level laser therapy shown to be effective in some cases of osteonecrosis of the jaw. How about the trismus, inability to open the mouth? What would be the risk? Again, it will be the cumulative dose of radiation therapy that can induce fibrosis of the soft tissue, or surgical-induced fibrosis. Again, treatment of trismus should be started early by educating the patient to do some exercises, passive or active exercise. Sometimes we can go for the therapide system. This is the device that helps to stretch the muscles. And then recurrent cancer, there will be a risk for recurrent cancer in those patients due to low grade of immune system. Like, for example, patients with a graft versus host disease, they have a chance to have another cancer. And there is a significant need for a long-term follow-up of those kind of patients. As you can tell, oral complication has a tremendous psychological and the social and economic impact, not only on the patient, but also on the people around them. So in a summary, we can say that cancer survivors are at a risk for developing a wide range of oral complication, which requires increased awareness and recognition to promote prevention and appropriate intervention. And this can be approached through a multidisciplinary healthcare team, which should be integrated, communicated in order to provide the best patient care in a coordinated manner at the appropriate time. Thank you very much for your attention.